Okay, the miscellaneous anti-cancer drugs are L-asparaginase, which hydrolyze the asparagine and given by IV route and IM and used in leukemia, and it has the hypersensitivity reaction, hyperglycemia and clotting abnormalities. Next is hydroxyurea, which inhibit the ribonucleotides to deoxyribonucleotides given by oral route and used in the leukemia, sickle cell disease and polycythemia vera, and it has the side effect of bone marrow suppression and GIT upset. Arsenic trioxide inhibit thioredoxin and generate free radicals and used in leukemia, and the adverse effect is leukocyte maturation syndrome. Okay, we'll just look at the overview of targeted therapy. Okay, there are several targeted therapies have been developed over the time. So there are growth factors and receptors in cancer cells, intracellular protein kinases in cancer cells, tumor angiogenesis, targeting the immune system and other targets. Okay, just know this briefly because this is just too advanced at your level. Okay, so growth factor receptor inhibitors, some of the examples are erlotinib and gefitinib used in metastatic non-small cell lung carcinoma. Okay, cetuximab monoclonal antibody binds to the EGFR used in colon cancer, and panitumumab monoclonal antibody binds to the EGFR and used in head and neck squamous cell carcinoma. Okay, the intracellular protein kinase inhibitors, examples are tyrosine kinase inhibitor of a fusion gene BCR-ABL. Okay, imatinib is used in CML, and dasatinib is used in CML and ALL. Cancer cells secrete vascular endothelial growth factor VEGF that induce angiogenesis or the new blood vessel formation. So this will provide nutrients to the tumor cells to grow and metastasize. So some of the examples of tumor angiogenesis inhibitors are bevacizumab and sunitinib used in renal cell cancer, and sorafenib is used in liver cancer. Immune system inhibitors blocks the immune checkpoints on the cytotoxic T cells to kill the cancer cells. So ipilimumab and interleukin 2 used in melanoma, and nivolumab used in Hodgkin's lymphoma. So the thing that you have to know regarding target therapy is the differences between targeted therapy or immunotherapy and chemotherapy. So targeted therapy, they are drugs that act on specific molecular target cells of cancer only, while chemotherapy act on the normal and cancerous cells. Okay, next, it is specifically designed to act on the targets, while chemotherapy was identified based on their killing mechanism of the cell. Next, target therapy targets the protein that would inhibit the cancer growth, while chemotherapy targets the dividing cells. So that's why it affects the normal cells as well. And often they are cytostatic. It means static the cells, and cytotoxic, but most chemotherapy are cytotoxic drugs. Now, the last subtopic of this lecture is clinical implications of chemotherapy drugs. So, chemotherapy drug combination as mentioned in one of the principles of chemotherapy. So there are several regimen developed to reduce the drug resistance and to reduce the side effects, and the goal of this combined chemotherapy is for complete remissions. So here are some of the examples. Okay, VAMP, vincristine, amitriptyline or the methotrexate, 6-mercaptopurine, and prednisolone is used in acute leukemia. ABVD, adriamycin or doxorubicin, bleomycin, vinblastine, and dacarbazine used in Hodgkin's lymphoma. MOPP, mecloretamine, vincristine, procarbazine, prednisolone used in Hodgkin's lymphoma. CHOP-R, cyclophosphamide, hydroxydonorubicin, vincristine, prednisolone, and rituximab used in non-Hodgkin's. And also used in non-Hodgkin's, the MP, the melphalan and prednisolone. For the breast cancer, there's CMF and FAC, which is cyclophosphamide, methotrexate, and 5-fluorouracil, and FAC, 5-fluorouracil, adriamycin, and cyclophosphamide. FOLFIRI and FOLFOX used in colon cancer, and BEP in testicular cancer, bleomycin, etoposide, and platinum. So now if we look at the disease one by one, okay, childhood leukemia has good prognosis when treated with the VAMP chemotherapy regime. There are other drugs that can be combined as well, but VAMP shows high curative rates. Okay, for the CLL, the COP or the CHOP regime works best. MOPP or ABVD regimen has been shown to cure Hodgkin's lymphoma patients, and the CHOP regime used for the leukemia also helps in non-Hodgkin's lymphoma, but usually as symptoms relief and not as cure. For breast cancer, depending on the staging of the cancer, stage 1 cancer usually treatable with the removal of the cancer, and stage 2 breast cancer is treated by surgical removal with the combination of the chemotherapy, CMF and or FAC. Okay, tamoxifen is useful in postmenopausal women and given for 5 years after surgery, and after 5 years patient is given anastrozole. For stage 3 and 4, chemotherapy drugs are given as palliative, and they include anthracyclines, macrotubule inhibitors such as taxanes and vinca alkaloids. Okay, colorectal cancer are also curable in stage 1, but in stage 2 and 3, chemotherapy drugs are given to prolong the survival rate of these patients. So patient responses can be seen as complete response, where there is complete disappearance of the disease, partial response, some disease still remaining in the body, stable disease, the disease remain the same, and progressive disease, disease which has increased in size or number on treatment. There are several painkillers that can be given to cancer patients. Okay, the first step in weak pain, we can give paracetamol, acetaminophen or NSAIDs. The second step is moderate pain, we can give codeine, tramadol with PCM or NSAIDs. And the third step is when the patient have severe pain, we have to give strong opioids such as fentanyl patch or morphine injection or petidine injection with PCM or NSAIDs. The toxic effects of anti-cancer drugs. include acute toxicity, such as severe vomiting, allergic reactions, and arrhythmias, delayed effects, such as mucositis, alopecia, bone marrow suppression with decreased leukocyte production, and thus patient is prone to infection. Chronic toxicities such as impaired wound healing, stunted growth in children, and teratogenicity. And specific adverse effects of specific drugs. Okay, cyclophosphamide, the alkylating agents, there will be bladder toxicity, and then doxorubicin, cardiotoxicity, bleomycin, pulmonary fibrosis, and the platinum compounds, the cisplatin, carboplatin, can cause nephrotoxicity, neurotoxicity, and ototoxicity. Okay, patients on anti-cancer drug can develop resistance to the drugs. So either primary or inherently resistant without any prior exposure of anti-cancer agents, and acquired resistance with the exposure to the anti-cancer agent and affecting the gene expression of the tumor. So the examples are anthracyclines, vinca alkaloids, taxanes, chemtoxins, and epipodophytoxins. So this is why the combination of chemotherapy is important to help in reducing this drug resistance. That's all for my lecture. Thank you very much. You can ask me question through my WhatsApp or my email. Assalamualaikum warahmatullahi wabarakatuh.